So thank you very much, Amarjit, for inviting me to this program. And I think the morning has been very enlightening. Lots of things happening here. So what I would like to do in continuation, I may be repeating a bit, but I want to supplement those talks. Those have already happened in the morning. Next slide, please. What I will do is, to those of you who do not know much about the Indian context, I will just briefly talk about the recent developments in India in the field of Ayurveda, NCDs and health seeking in India. What is the developing evidence in the last couple of years, and how is it relevant to the Ayurveda UK community, and what potential future directions we can have. Next slide, please. Yeah, so I think the last 2 decades has seen a big change in the field of Ayurveda. From the 2000, we have had lots of national programs that are integrating Ayurveda. The National Health Mission, Ayurveda is part of it. There is increased focus on clinical. So there was a 10 years report that was published by the Ministry of Ayush in India, and they talk about the increased focus on clinical and public health, research, technology, and a lot of reforms happening in Ayurveda education. Of course, globalization, lots of chairs have been created in many different countries, so lots of ambassadors are around, and focus on quality control. And as Professor Bhushan already mentioned, there has been a lot of effort to create evidence during the COVID period, or analyze evidence. And this has really boosted the research base within the Ayurveda. And from 2010, now it's part of the NPCDCS, which is the National Program for Prevention of Chronic Diseases. But there are, of course, challenges because there are obviously evidence gaps. Then research capacities are still developing. The educational standards, as previous speakers said, challenging. And within India also, we have this friction between conventional medicine and Indian medicine, and be it in terms of the financial allocation or be it in the creating space for research and so on. The collaborative working is a big challenge. Next slide, please. So what the second part is about the health-seeking behavior. So recently, the National Sample Survey Organization came out with the 2024 data, and what it says is that awareness about Ayurveda is increasing both in rural and urban India. So this is the 79th round NSSO, and around 46% of rural and 53% of urban individuals used Ayush prevention for treatment of ailments in the last 1 year. And this is very interesting data because this was not the case in 2014 NSSO round. It was only around 7%. So post-COVID, there is a huge attraction to Ayurveda and Ayush systems in India. Now, regional studies also indicate that there is a huge health seeking through Ayush in the post-COVID era. And studies suggest that 35 to 50%, Professor Besson mentioned about it, self-medication is also becoming very important because in India, also private healthcare is very costly, and 78% of our health seeking is through private sector. So there is self-medication, self-reliance on medication and so on. But we need more rigorous studies on the social dimensions of it. There are limited studies. Next slide, please. So what I'm trying to do today is, with respect to NCDs, where is the evidence level that is standing in Ayurveda? So there is as I mentioned, in the last 20 years, there has been substantial growth. But where do we stand today with respect to major diseases? So as you would see, what I'm just trying to do is to do a scoping of the PubMed index journals and show what types of studies are there. It will be individual drug studies or integrative concepts like what Darshan mentioned, and also on therapeutic procedures, which are very widely prevalent in India. What level of clinical data is available for us? What is the status of systematic reviews and meta-analysis? So you would see, if you check for Ayurveda in any index database, there will be around 9,000 citations. And this is growing from the period of around 2006. We don't know why it is suddenly starting to grow. And then by 2010, 2011, the indexed materials are really growing. There is a reason, because Journal of Ayurveda and Integrative Medicine came in around that period. There were other indexed journals in Ayurveda that came together. So around 2010, and last 14 years, the research evidence is growing substantially. And that is so, but compared to acupuncture, for instance, it's around 50,000 citations. So you can see where do we stand exactly. But there are limitations. There are non-exhaustive. This is not an exhaustive review because I've looked at only PubMed data. And often exact correlation is not possible. That's mentioned about the epistemic correlation issues and one-to-one correlation. The disease categories, the disease classification systems are different. So those are there, but within that limitation, I'm trying to show you how the evidence is emerging. And there is the linear approach. Comorbidity. So interpretation of non-communicable diseases is not so easy. But what I want to say is in this slide is that from 2006 to last maybe 20 years, the evidence level is growing. Next slide, please. So if you look at diabetes mellitus, for instance, and so if you will see around 475 citations, and these are the commonly used individual drugs, Tinospora cordifolia, curcuma, Phyllanthus emblica, gymnema. And why this is important for UK is that if we are to make evidence dossiers, I think these are the most repeated remedies in index journals. Then there are about polyherbal formulations, the evidence is growing, like Nishamalaka or Triphala. Triphala is very commonly used even in the UK. And if you come to the therapeutic procedures, this is one area the evidence level is very low. So like Vamana, induced emesis or Virechana, purgation or medicated enemas, the evidence is going. This is Salacia reticulata, one of the most commonly used plants for diabetic patients. It has the word, but it's not very commonly available. Now, we talked about the interface between Ayurveda and biology studies, and that's also growing. So for instance, in diabetes mellitus, there are studies now suggesting staging of disease, what we call as Kriya Kala, and how early prevention can be achieved. Those are very interesting. Then there are Prakriti as biomarkers for prevention. So for a Pitta Prakriti, if you get diabetic, what is the likely complication? So those kinds of studies are also going. And also biome-based research, like modulation of gut microbiota and Ayurveda health and diet lifestyle. Gut dysbiosis, how it happens and how proneness to diabetes will be there. And these are all not very rigorous studies, but these are very exciting studies to show way to new Ayurbiology researchers, and nutrition-based approaches are growing. So in summary, if you look at the clinical evidence, in diabetes mellitus is where maximum evidence is available, where case reports are there on complications, be it retinopathy or peripheral neuropathy and so on. Foot ulcers. The clinical trials is around 17, and randomized controlled trials is around 10. Systematic reviews around 9, meta-analysis 2, and whole system trial. Like we talked about the systems approaches, and there are very few studies still in India because all these are individual studies. So whole system trial is only one, and there is only one clinical practice guideline. This is very important to know. India has the CGHS in India has standard treatment guidelines, but no rigorous clinical practice guidelines for practicing for diabetes. And this was developed by Dr. Kaushik Upadhyay from here, University of Nottingham. Yeah, so this is the only CPG, but we are now working around some researchers and developing some CPGs on other procedures. Next slide, please. So cancer has maximum citations. These are the very commonly. Tinospora, a lot of evidence. Ashwagandha, a lot of evidence, etc., etc. Curcumin, maximum citation for curcumin. Curcuma longa. Professor Rajiv Gupta already talked about it. And polyherbal formulations, there are some unique formulations that have got some evidence, like Rasagandhi, Medugu, Jasada Basma, and so on. When therapeutic procedures, again, very limited, but mucositis, for instance, radiation-induced mucositis, like there are couple of practices with different medication, which is showing very good in. So chemo radiation related injuries, there is much more evidence. Now, Ayurveda biology studies, again about the Kriya Kala, the staging of disease in Ayurveda, and how it can influence cancer and its early prevention, or even to the terminal stages, what can be done. There are these diagnostic tools that are also developing, like Thaila Bindu Pariksha. These are new diagnostic tools based on your phenotypes, and that is also microbiome modulation, network pharmacology. Triphala, Professor Bhushan did a work on Triphala and its network pharmacology. So that was a very interesting article. So totally around 12 clinical studies, 5 RCTs, systematic reviews around 11, meta-analysis around 2, no CPGs and no whole system trial. But what you have to see is that I was discussing with colleagues in LSSTM yesterday. So for ashwagandha, there may be 9 randomized clinical trials, but that is not used for cancer or neurological condition. That is used in thyroid or some other condition. So I'll quickly go through the other diseases. Next slide, please. Yeah, cardiovascular, less citations. Arjuna Rita Triphala, Hridaya Varasa, there is evidence. Then there are these medicated enemas which are getting more evidence. So these are the evidence level on thing. Terminally Arjuna, which is one of the most sought drug, and also Desmodium gangeticum. These are very highly cited. Next slide, please. Coming to arthritis, a lot of RCTs are there. 7 RCTs are there. So this is the evidence level. And Panchakarma procedures also you can see. And I think in NHS effectiveness gap, I think arthritis and rheumatoid arthritis is especially suggested as one of the areas. So this is the level of evidence. Tinospora, a lot of data. Commiphora mucul, a lot of data. Guculipid and so on. Next slide, please. Neurodegenerative diseases, again, a lot of candidates, individual drugs. Next slide, please. Chronic respiratory disorders. There is very less evidence. Actually, Professor Marilyn Wilcox from University of Birmingham is online. We were doing a review of Payyappalli, and we found very less data on Payyappalli. But while it is being used extensively in India. Next slide, please. Next slide. Yeah. Yeah, so chronic kidney disease, again, limited. Stroke, one of the most commonly treated in Ayurveda. Through Ayurveda, there is limited evidence, but we have a very interesting, from our university hospital, there is an observational study on acute ischemic stroke, and that's published in PLOS. So next slide, please. Next slide, please. So yeah, if you go to Cochrane reviews, there are only 4 Cochrane reviews on Ayurveda. And what is ironic is that after post 2011, there has not been any thing. And I think the first one was in 2006 about irritable bowel syndrome, schizophrenia, anorectal fistula, and diabetes mellitus. But what is interesting is Cochrane Central Register for Clinical Trials. Ayurveda has 3,421 citations, and from 2020 to 2128, from 2020 there have been 2,128 clinical trials registered. This says very much, because this says that last 4 years there has been a lot of clinical trials, those are going on, and if all of them get published in good journals, I think we will have much more evidence-based. Yoga is also very significant. Yoga has around 6,028 registered clinical trials from 69, but from 2020, it's around 2,036. For acupuncture, Cochrane reviews are around 143. Yoga, it's around 58. TCM is 68. These are sourced from these databases. Next slide, please. So the observations that I make from this review is that the high health-seeking behavior that Darshanji mentioned is not getting translated into evidence base on the PubMed, etc. Largely individual plant-based medicine, there are insufficient evidence through whole system trial or RCTs, limited framework for integrative research that we talked about earlier, and insufficient health economic studies. As a social scientist, I'm very keen to look at this data as well. So we need more hospital institutional analysis, as Professor Darshan mentioned earlier, and we need large case series because there's huge data in the hospitals in India. So, and strengthening knowledge base, this Professor Rajiv Gupta talked about. I think on positive health and systems approaches of Ayurveda-based concepts like personal preventive health, cross-cutting concepts relevant to NCDs like inflammatory markers, nutrition, etc., etc. This is the area where we need a lot more focus because these are cross-cutting areas for NCDs. Next slide, please. So now quickly, my second part, and I will end it with this. If you look at the NICE guidelines in UK, there are 32 acupuncture guidelines. TCM has around 6, around yoga has around 6. And it's very interesting. There are like both for TCM and yoga. So in certain instances, eating disorders and recognition and treatment, no yoga should be done. That's the guidance. Intrapartum care, no yoga should be done. So some traditional Chinese medicine is also banned in certain stages or contraindicated in certain NICE guidelines. And on herbal medicine, there are 17 of them. But from India, not Ayurveda, from India, there are only 2 guidances. And one is on antigraphis paniculator on cough, upper respiratory infection. Second is the antenatal care. So this is the level of appreciation of Ayurveda in the NICE guidelines in the UK. So I just wanted to contrast that. Next slide, please. So when I reviewed, as a social scientist, I reviewed also literature around the health system in the UK. What I see is that there are very significant terms like effectiveness gap in conventional medicine, where arthritis is a very important area, unmet needs. So I think we need to really do an appraisal of what this is. Then chronic disease and multimorbidities, because for complex situations, the GPs are not able to handle that because of the multimorbidity issue. Of course, evidence base is repeatedly there in the literature. GP as a gatekeeper, how GP can work as a gatekeeper between Ayurveda system and of course, patient and treatment choice. Amarjitji, we mentioned, discussed that. Preventable ill health and self-management. Of course, social prescriptions. I'm not an expert to talk about it, but I think these are certain entry points, especially in the NHS, where we need to look at evidence. Next slide, please. So this is the Smallwood report in 2003, but it has changed. And I think this morning somebody mentioned that, yeah, you mentioned that the morbidity profile and the health seeking has changed. So we need more interesting studies. Next slide, please. So potential immediate steps, 2 more slides, I will close with that. I think we need to create a systematic knowledge base on patient demand and prevalence for Ayurveda in the UK. And I think certain social scientists should be able to help that. And study patients coming to India for wellness and curating. Many people have called us with long COVID. They want to come to India for Panchakarma and so on. But we don't have that immigration data because this is not. So we need a program. Why people are coming to India for Panchakarma or wellness treatment? That kind of data we need to generate. Then, of course, we need to create systematic dossiers. I gave examples of plans where you can create those dossiers because I worked in Japan health system for quite a while. And I know that Japan, for 142 plants, they just created these evidence dossiers. And so in a high-income country, the context is very different. Because in India, pluralism is very open. So in a high-income country, I think you need to really create evidence. Then, of course, evidence synthesis on low-hanging fruits like Panchakarma and Marma therapy. Because why is acupuncture getting so much popularity? Because it's non-pharmacological, non-invasive. So I think we need to look at Marma and Panchakarma, etc., and develop a stronger knowledge based on personalized preventive health. And I think there is an NHS England guidance involving people in their own health and care. It's a statutory guidance for clinical commissioning groups in NHS England for 2017. I think this is where the personalization and preventive health possibly can locate in a policy frame. Next slide, please. So the longer term strategies, I think we are already building certain academic collaboration with universities here. We just wrote a proposal for antibiotic reduction on with Birmingham, sorry, with Southampton and so on. We have some collaboration with Birmingham now. And collaborative research on specific aspects like NCDs, multimorbidities through whole system trials. And WHO recent report suggests that almost 30 countries are practicing Ayurveda today. So we can collect a lot of clinical data from these 30 countries with joint investment that Professor Darshan mentioned, and building stronger collaboration between Ayurveda and biomedical practitioners, which is what Amarjit ji is suggesting today. And how orientation of GPs and how they can facilitate it as a gatekeeper. Next slide, please. Yeah, so it's a bit ironic. This is a Lancet publication from 1900, and this is by William Mayer, who's a biochemist, and he was working in Calcutta that time. And he wrote a review because there was a colonial addendum to the British Pharmacopoeia in 1898. And this review, this is a very interesting, extensive review published in Lancet. And I think after 125 years, we are still discussing how to get one or two drugs into the nice guideline. But I'm really hopeful from Indian side, the evidence level is growing. So I think that will be able to clearly support the also in initiations in other foreign countries. Thank you very much.